commercial support. And in case you missed the 2024 annual meeting, the on-demand recordings are available for purchase, and you can go to this website and see those on the IARS website. And don't forget, the 2025 annual meeting is right around the corner, and abstract submission is now open. It's in Hawaii this year. The deadline is Sunday, November 3rd, and so please submit your abstracts for this conference. After the webinar, join the speakers in the IARS member community to continue the conversation, and you can see the Doc Matter website right here, and you can have a lot of online conversation about all the things that you will learn and review today. There are several other upcoming webinars from the IAS Virtual Education. Global Critical Care, the Crisis and Way Forward, will occur November 12th. Interesting articles you may have missed from the subspecialty ICU literature is going to happen December 10th. Both of those are at 4 p.m. Eastern Time, so please look for those and register. And while the speakers are speaking today, you can submit your questions via live Q&A. So please use the Q&A button on the Zoom taskbar to submit your questions, and we will answer them all at the end. And so now it gives me great pleasure to introduce our 4 speakers today. They're all going to talk about current controversies in critical care, and the topics are great. I want to first introduce kind of the leader of the panel who put this together, Dr. Kunal Karamchandani. Kunal did a lot of his training in India, where he earned his medical degree and also did a residency in anesthesiology. He then came and did another residency in anesthesiology at Cleveland Clinic, followed by his fellowship in critical care. He's been practicing anesthesia and critical care for about 10 years, and he's very active nationally. He's on the SOCA Board of Directors and is chair of the SOCA Education Committee, organizing much of the IARS and SOCA annual meeting this year. We then will have Somnath Bose. Somnath earned his medical degree from Calcutta Medical College. He earned his residency in anesthesiology and then completed a fellowship in critical care medicine from Cleveland Clinic. He then went on and got an MPH from Harvard, and he currently works at Beth Israel in Boston. He has numerous publications on peri-op outcomes, with several recent publications on post-ICU syndrome, which he's going to talk about today. Next, we will have Dr. Ashish Khanna. Ashish completed his residency in anesthesiology at Cleveland Clinic, followed by his fellowship in critical care medicine. He now works at Wake Forest in North Carolina. He has numerous research interests, especially those in hemodynamics, and he's actually the inaugural president of the Perioperative Outcomes and Informatics Collaborative at Wake Forest. He is a fellow of critical care medicine, the ASA, and the American College of Chest Physicians. He serves on the SOCA Board of Directors. He's chair of the American Society of Anesthesiologists Critical Care Committee, and he has numerous leadership roles on the FCCM. He's very active nationally and also publishes so much. I think he has over 180 peer-reviewed articles currently. So a wealth of information, and we look forward to his talk today. Dr. Kristen Rock will complete things. She earned her medical degree at Harvard, followed by her anesthesiology residency at Thomas Jefferson, and then she completed a critical care fellowship at the University of Pennsylvania, where she stayed on staff and currently works as an anesthesiologist and intensivist. Kristen is heavily involved in fellowship education and also has numerous publications concerning peri-op outcomes. So with that, I would like to pass it off to Kunal for our first talk.
Thank you, Brigid. Let me see if I can get my presentation up. Share. And all right, looks like it's up now. All right, thank you, Brigid, for the kind introduction, and thank you, IARS, for this opportunity. Now, as part of the session where we're talking about the challenges or the controversies in critical care in this age and era, I would be discussing the pros and cons of analgesia-based sedation for critically ill patients. Here's a list of my disclosures, none of which is relevant to the talk today. Now, during this talk, I would be starting off by talking about the importance of appropriately assessing and managing pain in critically ill patients. We'll then talk about the concept of analgosedation, what it is, why it came, and so on and so forth. We'll then take a deep dive into the problems associated with analgosedation, or more specifically, opioid-based sedation. We'll talk about iatrogenic acute opioid withdrawal, persistent post-ICU opioid use, and briefly about opioid-induced delirium. Now, for those of us who work in the ICU, we know that pain is extremely common in critically ill patients. In fact, it has been estimated that it is the most common memory that the patients have of their critical illness and is a leading stressor for those that survive critical illness. The incidence is variable, again, depends on which patient population we're talking about. If we look at the cardiac surgery and trauma patient population, the incidence is as high as about 70 to 80%. If you look at a mixed med-surg cohort, almost 1/3 of these patients have pain at rest, and about half of these patients have pain during a procedure. Now, when we talk about pain in the ICU, we can broadly classify it as constant or continuous background pain and intermittent pain. Postoperative patients with their incisions and drains tend to have constant pain because of that. A lot of patients have, chronic pain, which gets exacerbated in the ICU. For example, patients with chronic back pain, they're not able to ambulate, not able to move around. So then their chronic pain becomes an acute persistent pain. Patients with trauma in the form of amputations, fractures, those that develop pressure sores, soft tissue injuries, again, these patients tend to have a constant pain as well. When we talk about intermittent pain, again, all the invasive procedures, whether it's central line placement, arterial line placement, catheters, nasogastric tubes, and so on, lead to this intermittent pain. An interesting part is that almost everything that we do in the ICU tends to cause this intermittent pain. And this was illustrated in this study, which was probably the biggest study looking at pain in the ICU. This was a prospective cross-sectional, multi-center, multinational study, which kind of looked at almost every routinely performed procedure in the ICU and how the pain associated with that differed from the patient's baseline pain. And if you look at this table here, almost every one of these procedures is associated with significant pain. And these are the patients that were able to describe and self-report pain. So we know that pain is extremely common, and it often goes untreated in this patient population. And this untreated pain then has both short and long-term implications. When we talk about short-term, this untreated pain leads to a significant inflammatory response, affecting and impacting almost every organ system, as we can see in the figure here. This all leads to increased morbidity, mortality, ICU and hospital length of stay, and all this kind of adds on to increase your healthcare costs. In the long term, this untreated pain causes anxiety, depression, post-traumatic stress disorder, and an entity called chronic intensive care related pain, which we'll talk about in the next slide. And this contributes to what has been described as the post-intensive care syndrome, which I think Som is going to talk about after me. Now, when we talk about this chronic intensive care related pain, there are variable definitions that are there in the literature. The two that I found which were more relevant and most widely used were pain lasting more than equal to 6 months after ICU discharge and pain persisting or recurring 3 months after ICU discharge. The incidence of this chronic intensive care related pain is kind of just like the pain in the ICU, variable and depends on the population, the point in time it was assessed, and the type of tool that was used to assess it, but ranges anywhere from like 15 to 80%. So I think what we can say based on what I've presented so far is that pain is common in the ICU and it needs to be appropriately assessed and adequately treated. The question is how? So in 2013, the Society of Critical Care Medicine, in their pain agitation delirium guidelines, introduced the concept of analgosedation. What they proposed was that we should achieve pain management first and then use sedation as needed, or what was called the analgesia-first approach. Again, if we use this, you use less sedation and potentially improve outcomes. You have fewer days on mechanical ventilation, shorter ICU length of stay, and this has a positive impact or decreases the incidence of ICU delirium. Now, the problem is this analgesia-first sedation, which was described, slowly got converted, and people started using analgesia-based sedation, where we had patients who were on an opioid infusion to facilitate and tolerate mechanical ventilation. Now, this has its own problems, and let's talk about these problems in detail. Let's start with opioid tolerance. Now, even in ICU patients who receive opioids for long term, have larger doses, and if using potent drugs like remifentanil, they can develop opioid tolerance. Another area of concern is iatrogenic opioid withdrawal. Although it's been very well described in pediatrics, there has been limited data in critically ill adults. But as I'll show in the next few slides, more recently, more and more interest has been generated in this entity. So this was first described in 1998. This was a small retrospective study looking at 28 patients who were in the trauma and surgical ICU, and 1/3 of these patients developed this iatrogenic withdrawal syndrome. And patients who developed this syndrome, of course, had higher both mean and peak daily use of fentanyl equivalents. Another more recent study published in 2017, again looking at level 1 trauma ICUs. This time they had slightly more number of patients, but again, the results were similar. I mean, there was a significant incidence of iatrogenic withdrawal syndrome in these patients. Now, a more recent study that just came out last year now specifically looked at MICU patients to see if the same entity was present in these patients as well. This was a single-center prospective observational study which evaluated patients who had received more than 24 hours of continuous opioid infusions and found that the incidence of moderate or severe iatrogenic withdrawal syndrome was about 12%. And again, the results were pretty similar. If you received, or if the patient received more than 72 hours or a longer duration of continuous opioid infusions, or if they received a higher dose of opioids, they were more likely to develop iatrogenic withdrawal syndrome. Another area of concern when we use analgesia-based or opioid-based sedation is the development of ICU-acquired opioid dependence, more likely in opioid-naive patients as well as post-surgical patients. Now, a practice that, a lot of times we follow is that when we have patients on these opioid infusions, we transition them to enteral opioids. And this actually came across from a study from 2012 where they first looked at use of methadone, and they found that patients who were transitioned to methadone had faster weaning from mechanical ventilation. So since then, we've tried to use this technique for patients who receive these opioid infusions. But the problem is that if you start them on enteral opioids, they kind of continue on these enteral opioids and they are discharged from the hospital as well. So let me show you some data around this. So the first study that Brigid and their group from Duke did was a retrospective single-center study, looked at opioid-naive adults who were receiving opioid infusion and concomitant enteral opioids. And in their cohort, they found that almost 30% of these patients were discharged on opioids when they were not receiving any opioids before hospital admission. We did a study as well. This was looking at opioid-naive, non-surgical, critically ill patients. And in our patient cohort, we found that about 40% of these patients were discharged on new opioid prescriptions. Now, among the risk factors, the interesting ones were patients who had a longer hospital length of stay and had more time between their ICU discharge and hospital discharge were more likely to receive these prescriptions. So what's the problem if you discharge these patients on new opioid prescription? It can lead to persistent opioid use in these ICU survivors, and I'll show you some data behind that as well. So this is not an ICU study, but this kind of looked at patients who were discharged on opioids and the incidence of chronic opioid use. These were hospitalized patients, but it was interesting. Patients who were discharged on an opioid prescription were more likely to develop chronic opioid use. Now, we looked at the veterans database for this. We looked at opioid naive veterans who had a postoperative ICU stay more than 24 hours and looked at their incidence of new persistent opioid use, which we defined as continuation of opioids more than 3 months after discharge. About 4% of these patients developed this new persistent opioid use. But the good part about our observations was that this incidence was slowly trending down. Now, around the same time, Hannah Wunsch and their group also published a similar study looking at mechanically ventilated opioid naive adults in the ICU. And what they observed was that these patients had a persistent opioid use, and the surgical patients were 2 times more likely to do that versus the medical patients, which is something similar to what we found as well, that the incidence was about 4%. Now, this is a more recent study. I think this came out this year, which kind of looked at what happens if patients receive more opioids in the ICU. Again, if you look at the curves, patient who had more opioids were more likely to have the opioid prescriptions in the year after discharge, and again, persistent opioid use after hospitalization. Now, this study went a step further. So you discharge these patients on opioids, they develop this chronic new persistent opioid use. What happens with that? Does it have any impact on mortality? So this was an observational study from Swedish ICUs, and they found that patients who were on this chronic opioid use were more likely to die as well. So essentially, what we're trying to take away from this is that patients who receive these opioid infusions get started on enteral opioids, which then get continued on hospital discharge, which then get continued as persistent opioid use, which may impact mortality. Now, towards the end, let me briefly talk about the role of opioids and its association with delirium in critically ill patients. So, this was a study that was published in 2021, looked at about 4,000 adult ICU patients, and the authors created this model to predict the risk of delirium the next day. And what they observed was that patients who received opioids or opioid use in general was associated with an increased risk of delirium the next day, and an increase in doses on opioids was associated with an equivalent or more increase in the risk of delirium. So, in conclusion, what we can say is pain is extremely common in the ICU, and it needs to be appropriately assessed and treated. Otherwise, this untreated pain can lead to both short and long term bad outcomes. Now, we need to be very careful when we use opioids and kind of have a clear discrimination between opioid first versus opioid based sedation. Transition of care and hospital discharge are 2 areas where we need to concentrate on and see how we can improve this inappropriate continuation of opioids. And then there should be a way to follow up these patients. And I think Somnath is going to talk more about the post ICU clinics and so on. But again, thank you so much for your time. And I think we'll take questions at the end. I'm going to stop sharing.
All right. Well, thank you, Somnath and Kunal. After that initial pain and recovery part, I'm going to get us all back into the intensive care unit and talk about biomarkers and specifically talk about renin and lactate and some of the new and rather exciting data around all of that. Again, thank you to IARS for this opportunity and for you all for sparing time on on an evening or a work day to listen in to us. As I said, my talk today is going to focus on renin and really, as the title slide suggests, is renin the new lactate, and and what are some of the new challenges in the assessment of the renin-angiotensin system. These are some of my current financial relationships. None of this is a perceived or a real conflict of interest with the academic content on my slide today, and I'm not going to talk about any off-label material. These are some of my other relevant disclosures, my work with FCCM and ESICM, and some of the relevant grants that are supporting the work that I will talk about in the next about 12 minutes or so. So starting with something very simple, we all know the normal RAS pathway, angiotensinogen, Ang1, Ang2, and downstream effects, and then renin and ACE being the mediators on that pathway. Um, we are going to focus on ACE and then renin. When there is ACE dysfunction, what is very obvious and sort of common sense is this. So when ACE is either low or dysfunctional, there would be downstream decrease in the production of endogenous angiotensin 2 and the vasoconstrictive cascade that results as direct actions of angiotensin 2 and secondary to the generation of aldosterone. But more importantly, and our focus today is going to be the upstream products. So the increase in renin being the most important one, and the effects on angiotensinogen and Ang1. Now, why renin? And I'll get to all of that, but I want to focus your attention on the classical pathway and the alternative pathway. So we've learned the classical pathway. I just showed you the classical pathway. We start talking about it in medical school, angiotensinogen, Ang1, Ang2, and then the downstream effects of Ang2 through the AT1R receptor. We now know, and I'll show you some of our latest evidence in slides to follow, that in situations where there's endothelial dysfunction, where there's acute lung injury, where there's severe shock, specifically septic shock, ACE is dysfunctional. ACE sits in the pulmonary capillary endothelium as a sort of the richest source for the generation of ACE. When ACE is dysfunctional, not only is there a decrease in production of angiotensin 2, there is also an increase in the production of angiotensin 1 to 7 and angiotensin 3 to 8 and 5 to 8. 1 to 7 through the ACE2 pathway, and then 3, 8, and 5, 8 through DPP3. Both ACE2 and DPP3 are extremely active in patients with septic shock and other situations of endothelial dysfunction. And all of this is very relevant because all of these byproducts are vasodilatory in nature and contribute, if anything, more to the severe hypotension that is very typical in refractory shock states. Now let's go back to renin for a second, and I'll come back to the alternative pathway as I proceed. So in the last 6 years or so, there's been a lot of interesting work that has shown that renin is a better marker of tissue perfusion and prognosis compared to the standard of care that's lactate. This is one paper I often talk about. This is a John Louis group in Brussels. They looked at about 110 samples across various types of shock in their intensive care unit. And what they showed was that not only was renin not disturbed secondary to diurnal variations or CRT or certain drugs, it did outperform lactate as a marker of tissue perfusion and prognosis. So, the obvious next question was, is renin the new lactate? And the present day answer there is probably no, because there is no way to do a quick bedside assessment of renin. Lactate, we don't even think about. We send a blood gas, we get real time lactate back as we are resuscitating our patients. But renin, typically in most institutions, is a send out lab. And even if it's not a send out lab, it takes about a week or 10 days to come back after processing. So there's no way we can use it currently as a real time assessment system. Now, the evolution of the evidence with renin has gone from institution to institution. So the early evidence I showed you was from Belgium. This is work from the group at the University of Maryland. Again, similar work, about 250 patients this time, 197 renin samples, 148 lactate samples. And what they showed was that, again, both absolute renin and lactate predict mortality, but it is the delta renin and not the delta lactate that has an independent association with mortality. This illustration here is telling a story. If you look at the top part of the panel, these are patients with renin more than 40 picograms per cc. and the proportion of dead versus alive, there is a significant difference in favor of high renin. Compared to that, the bottom panel is our traditional lactate, more than 2 millimoles per liter. Again, there's no discriminatory effect of that on the proportion of deceased versus alive. So again, higher proportion of folks who had renin more than 40 picograms per cc were non-survivors than survivors compared with the traditional lactate cutoff. Now, cycling all of this back to the use of agents that would modulate the renin-angiotensin cascade, our work with the ethos 3 trial had already shown the safety and efficacy of angiotensin 2. Here we had randomized patients with high output vasodilatory shock to either angiotensin 2 or continuation of standard of care at norepinephrine equivalent doses of 0.2 micrograms per kilo per minute. And back in 2017, as we had done post hoc analyses, we had also seen that ANG2 had modulated renin. So uh, baseline versus hour 3. Now, hour 3 was our primary efficacy endpoint with the ethos 3 trial. Patients who received angiotensin 2 had a definitive decrease in their renin levels compared to patients who continued on placebo or standard of care. This was definitive evidence that despite correction of hypotension, the placebo patients were not having any modulation of the RAS versus patients who received angiotensin 2. The RAS imbalance was corrected and renin was near normalized. Furthermore, and this is a part of the same post hoc analysis with Ronaldo Bellomo, if you follow the arrowheads on the solid red line, these are patients within the ethos 3 cohort that had renin higher than population median. These patients, when given or randomized to placebo, about half of them were diseased at a week out. About 80% were diseased at 4 weeks out. Compared to that, the solid blue line is patients with high population median baseline renins in ethos 3 who received angiotensin 2, and there was a distinct survival benefit in this high renin vasodilatory shock population. There's a lot of data, there's a lot of different parts and pieces to this evidence, and I've put it all together in this editorial. I'll just bring it up here for those who want to read it. I've compared the Maryland evidence, the work from Belgium, and then Ronaldo's work with us as we've looked at renin and outcomes in vasodilatory shock. So those who want to read it and summarize the evidence, this is the editorial. Now, more recently, we've looked at samples from the Victus trial. The Victus trial, famously known as the vitamin C, thiamine, and storage and sepsis trial. This is work where we collaborated with the Emory group and the Hopkins group. The biorepository samples were sent to our lab at Wake Forest, where Mark Chappell's group did the analyses. And what we've seen again is an almost exact replica of what has been seen in previous work with the Europeans and the group at Maryland. As renin increases, here the solid red line, there is a distinctive increase and very significant increase in the hazards of mortality. Now here we had samples at day 0 and also at day 3 after randomization into Victus. What we saw that this relationship persisted at day 3 as well. So patients who had high renins here in the blue curve had a poorer overall survival probability compared to patients who had lower population median renins. We also looked at the trend of renin over time. Patients whose renin decreased over time had a better survival probability compared to patients whose renins increased over time. And most interestingly, and rather alarmingly, in fact, we saw this disconnect between renin and angiotensin 2. We divided our renins into 4 quartiles of increasing renin. This is from the same Victus cohort. And then we looked at downstream angiotensin 2 production. Ideally speaking, as the renin goes up, the angiotensin 2 should go up and should have a pretty similar behavior. However, renin goes up to 60 times normal in the highest quartile, Angiotensin 2 only increases 2 times normal. This quartile 4 almost universally had mortality as an outcome. There is a total disconnect in the renin-angiotensin system in patients with severe septic shock. We've done further analyses into this, and we've seen, if you focus on the right side of the panel, that ACE2 and DPP3 are highly active in patients with septic shock, and then there is a total disturbance of the production of angiotensin 2 versus angiotensin 1 to 7. That is the D part of the panel on the left side of your screen. As there is worsening or increase in renin, angiotensin 2 production should go up more compared to Ang7. On the other hand, there is more production of angiotensin 1 to 7 than angiotensin 2. It shows a diversion of the pathway to the vasodilatory metabolites rather than the vasoconstrictive angiotensin 2. So in severe septic shock, there's an increase in vasodilatory metabolites, there's an increase in ACE2 and DPP3, an increase in angiotensin 1 to 7 that adds to the refractory hypotension. The lack of response to Ang2 is multifactorial. We're doing lots and lots of work now looking at the downgradation of the AT1R receptor and also at angiotensinogen production in the liver. Our current work has also compared septic shock samples to healthy controls, and we've seen what we theoretically anticipated. If you look at the left side of the screen, decreased Ang2 in septic shock, increased Ang1 to 7, the vasodilatory metabolite, and the ratio of Ang2 to 1 to 7 severely decreased in septic shock, showing a very low Ang2 and a very high Ang1 to 7. Furthermore, decrease in serum ACE in septic shock compared to healthy controls. The middle panel, increase in ACE2, which is the pathway that diverts to the vasodilatory metabolites, and again, the ratio being severely decreased in septic shock. And rather interestingly, both total and intact angiotensinogen are also severely decreased in septic shock. And there's more to follow with this. And the precision part here has led us to angiotensinogen, which is produced in the liver. And generally speaking, angiotensin 2 has a positive feedback on angiotensinogen. So high Ang2 will increase angiotensinogen, low Ang2 will decrease angiotensinogen. What we are seeing now, comparing angiotensinogen, renin, and lactate, and this is still under review, is that angiotensinogen appears to have the greatest predictability in terms of the overall survival probability compared to renin and compared to lactate. Lactate seems to have a fairly poor predictability of overall survival. And this, again, is the same way of showing the same effect of angiotensinogen. On the right side, you see the survival curve. So the angiotensinogen, renin, and lactate all compared. And more to follow with all of this. This is my last slide. I've made the point that renin is superior to lactate. We do need a set of precision biomarkers. We're working on that currently, looking at ratios of ACE, ACE2, Ang2, Ang1 to 7, and DPP3. We need biotechnology to develop point-of-care RAS testing. We do need dual antibody ELISAs for active renin. And ultimately, all of this will lead to RAS-guided resuscitation, precision vasopressor use. You can actually see and know if your patient would benefit from RAS modulation. And angiotensinogen seems to be the most predictive of them all. And it'll be interesting to see how that responds to exogenous Ang2 administration. Thank you all for your time. And this is all thanks to our center here. And I'll take questions afterwards.
Oops. All right, I'm sorry, I'm just trying to find my PowerPoint here. Okay. All right, I'm Kristen Rock. I'm following Dr. Khanna and talking a little bit about vasopressors and sepsis. We'll briefly touch on angiotensin 2 in that milieu, but perhaps from a little bit more of a boots on the ground standpoint. I have nothing to disclose, but in talking about some of the drugs today, I am talking in an off-label fashion about how we might be using them. Oops, wrong way. So those of us that work in critical care should be familiar with the Surviving Sepsis campaign and their 2021 guidelines, which provide some guidance on how we should be using vasoactive medications in the treatment of sepsis. And while they are certainly helpful and most definitely based on the evidence available, they do leave room for some questions on how we should be treating our patients with sepsis. Here are a few of the things that are not specifically addressed in these guidelines, including the timing of when we should be adding a second agent. They do recommend vasopressin for this. The dosing range of your initial agent, which they do recommend is Levophed, at which to add the second range. And then also, as your patients are getting better, when we should be de-escalating these agents, and the order if you have multiple agents at which we should be de-escalating. Taking a look a little more in depth at these guidelines, while they do have a strong recommendation for the use of Levophed as the first-line agent over other vasopressors, more specifically dopamine, in actuality, the other recommendations in the Surviving Sepsis guidelines, the quality of evidence is actually low, and the recommendation level for these recommendations is weak, which is a little disconcerting given that sepsis is one of the more common things that we treat here in the ICU. And soberingly, it still carries around a 40% mortality rate with millions of people being affected each year. So certainly more opportunities for us to think about how to better take care of our patients. This is a Cochrane review for 2020, kind of furthering that point of room to continue to think about things. While the norepinephrine is the first line vasopressor and septic shock, because it's been found superior to dopamine, there's actually more equipoising evidence for arginine vasopressin and epinephrine. And this review does point out that the authors of the Surviving Sepsis campaign recognize that certain evidence suggests that there may be room for other vasopressors in terms of clinical outcomes, but specifically for vasopressin, due to higher costs and lesser availability, they still recommended Levophed as first-line agent. And you can see kind of, I won't go through this slide in detail, but versus Levophed on the left and vasopressin on the right, perhaps there is a mortality benefit to vasopressin and sepsis. The same sort of slide you see here, instead of vasopressin, epinephrine is on the right. And again, a suggestion that epinephrine may also have a kind of more of a place in our sepsis treatment than perhaps the guidelines would suggest. Rather than talking about traditional vasopressors today, though, I thought I would talk about some other agents that are maybe vasoactive, but not necessarily vasopressors in and of themselves, but all of these are attractive because they physiologically make sense in terms of their mechanisms of action as being potentially helpful in sepsis. And they're also all choline sparing, which is certainly advantageous to our patients given the deleterious effects that high-dose catecholamines have, particularly used over long periods of time. And one of the themes that I've been thinking about in preparing for this talk, certainly, and in general in taking care of septic patients is, should we be thinking of hemodynamic management in sepsis as we think of pain management as kind of a multimodal therapy instead of the traditional stepwise escalation approach based on solely on a MAP goal or a hemodynamic goal? So the three things I was going to briefly talk about were angiotensin II, which we talked about in more detail with Dr. Khanna's presentation, methylene blue, and hydroxycobalamin. So angiotensin 2, you heard more eloquently from Dr. Khanna than I could ever talk about the mechanisms behind angiotensin, and certainly the ATHOS-3 trial, which I think was a really exciting trial that's suggesting that that maybe angiotensin 2 has a role in addition to our vasopressors in sepsis. Disappointingly, at my institution, we do not have angiotensin 2 available, and the discussions around that were due to primarily cost, and the unfortunately that the ATHOS-3 trial was not powered to detect a mortality benefit, and that was really what our pharmacy committee was wanting in terms of using this expensive drug. So I'm hopeful that in looking at angiotensin 2 further, and maybe looking at some of the post hoc analysis, which may suggest a little bit more of a mortality benefit, that perhaps we may be continuing to talk about the benefits of exogenous angiotensin 2 for our patients. So this post hoc analysis came out last year, and what they did was group these original ASO3 patients into a low norepinephrine group and a high norepinephrine group at the onset of administration of angiotensin 2. And those were defined at 0.2 micrograms per kg per minute of levofed. And interestingly, the Apache scores and the SOFA scores were pretty similar between all of the groups, with the exception of the placebo group in the high norepinephrine group, suggesting that the patients that were receiving less levofed weren't necessarily less sick. And as you can see in the Kaplan-Meier curve, there is a mortality reduction for those patients receiving the study drug. Additionally, the incidence of renal recovery, defined as the cumulative incidence of discontinuation of renal replacement therapy, was also lower in the angiotensin group in both the low levofed and the high levofed arm, and there were less safety events for the study group. This is yet another post hoc analysis of the ASO3 trial, where they looked at patients requiring a renal replacement therapy at the time that they were randomized to either the placebo or the angiotensin treatment group. And similarly, there was a 28-day survival that was statistically significant for the treatment arm. And they also had a greater liberation from renal replacement therapy, which is kind of a second theme of suggesting where we could go in terms of sepsis treatment. Mortality, well, obviously the holy grail. I think there are other endpoints that are equally as important, or at least important enough to think about in using a drug, such as renal protection and liberation from renal replacement therapy. I think that that's certainly something that we all are hoping for our patients. So hoping that there's more to come, and at least more availability for angiotensin 2 for the treatment of our patients in the future. Moving on to methylene blue, this is not a new treatment. Methylene blue has been around for quite some time. Certainly we've seen this and been familiar in the treatment of methemoglobinemia, and many people use it for the treatment of vasoplegia, particularly in our cardiac surgery population. And the idea that we might be using methylene blue in sepsis is not new. The first trials were done in the early 2000s. And again, the mechanism of action of methylene blue makes sense in this patient population insofar as it's a nitric oxide scavenger and a selective inhibitor of inducible nitric oxide synthase, which will help with vasoconstriction. With that said, even though this has been looked at before, there's only 13 studies in the past 25 years and a total of 138 patients in all of those studies combined. And there was significant heterogeneity in the dosing strategies of methylene blue, whether it was given as a single bolus or a continuous low dose infusion. So really hard to make any sort of definitive conclusions from the data that we have. What these studies generally show is that there's an increase in mean arterial pressure by an average of 10 to 25 for the duration of the drug administration, followed by a return to baseline, and there's certainly no difference in mortality. But it is worth mentioning that all these studies, the mortality rates for these patients were quite abysmal, certainly more than the 40% mortality rate for sepsis that we're hoping to beat. This is 70–80%, suggesting that these were patients that were given methylene blue as a salvage therapy, and suggesting that perhaps if we are thinking of this as more of a bundle and giving these drugs earlier in a sepsis course, that perhaps they may be more efficacious. In line with that thought, this is again a retrospective cohort study of very few patients, so certainly nothing to make any sort of conclusions about, but they did look at patients who were administered methylene blue at very high levofed doses, and they grouped them into people that responded as defined as a reduction in your norepinephrine dose, and non-responders. And they found that the responders had a significant mortality benefit, again, small sample size, and that the non-responders, people who did not have a reduction in their levofed dose, did have differences in the degree of tissue hypoxia, as they defined, related to the degree of metabolic acidosis and the ratio of venous to arterial carbon dioxide tension and arterial venous oxygen content. So again, just kind of bringing this up to suggest that maybe we could be looking a little bit more carefully as to the timing of our administration and perhaps the types of patients that we're giving methylene blue to, if we were to do more investigations of whether this is a drug that would be helpful to our septic patients. And lastly, to touch on hydroxycobalamin. This is kind of in the similar vein to methylene blue, a nitric oxide and hydrogen sulfide scavenger, and also inhibits inducible nitric oxide synthase. It's also been around for a while and is cheaper. So at my institution, I can't get angiotensin II, but I ordered hydroxycobalamin yesterday on one of my septic patients. Whether that was a good idea or not, I'm not sure. But there are some feasibility studies and some data coming out on this that hopefully might guide that decision. So this was, again, a feasibility study of using high-dose hydroxycobalamin, as described as a single 5-gram dose, within 24 hours of ICU admission for people meeting sepsis criteria with a levofed dose of 0.1 mg per kg per minute. As a feasibility study, that was the primary aim, but the secondary outcomes included a reduction in vasopressor dosing, which they did find in their study. This was only 3 hours after randomization or the reduction in vasopressor was only 3 hours after the dosing of the hydroxycobalamin. So certainly not an outcome that we would really be basing any clinical management on. But I'm hoping that we might see more data in the future that may suggest this may be helpful for our patients. So with that, in conclusion, still lots of room to think about how to treat our patients with both vasopressors in a traditional sense and perhaps some vasoactive agents that are non-catecholamine. Perhaps thinking of this more as a bundle versus a rescue therapy or a stepwise approach to vasopressor use. Thinking of precision medicine, maybe certain patient populations that may benefit from one thing versus the other. And examination of alternative outcomes to mortality that are still valid endpoints to helping our patients recover from septic shock. That I will stop sharing. I'll try to stop sharing.
Thank you, Kristen. Thank you to all our speakers. Those were excellent talks and hit on a lot of controversies. There were several questions raised, so I'll just start with the ones in the chat, if that's okay. And I see some of you have answered via text, but Kunal, there were a couple of questions about ketamine. So people are really curious about ketamine and chronic pain. Can you expand on that?
Sure. I think ketamine, just for the sake of it, doesn't make sense. But in patients who have a chronic opioid use and now in the ICU, I think there is a definite role for ketamine if you can go along with the logistical challenges, which I think almost all the US institutions face with regards to the use of ketamine. But I would say if you look at data, especially in postoperative patients who are on chronic opioids and are in the ICU, it definitely helps wean them off mechanical ventilation faster and things like that. So I would say there is a definite role for ketamine. I won't use it for all patients, just like we tend to do in anesthesia, where we're giving everybody ketamine, whether they're having a cystoscopy or an endoscopy and so on. But I would selectively use ketamine in patients who have chronic opioid use and are admitted to the ICU.
Okay, thank you for that. I was just going to skip around. Ashish, there was a question about renin. And do you think renin is altered by angiotensin II infusions? Or is renin something the body is doing, angiotensin II isn't really altering, and your findings are kind of a true unrelated? Can you speak to that?
Well, we have clear evidence that renin is, well, let me reframe this. We have clear evidence that ACE dysfunction then sets off a cascade which leads to decrease in downstream production of angiotensin II. That then imbalances the renin-angiotensin cascade, leads to higher renin, and then we do have evidence that giving exogenous angiotensin II then resets this high renin. Now, if the question is, are some people just carrying primarily a higher or a lower renin to start? Well, I think that part needs to be investigated. We do know that there is a normal renin, and then there is some variation in population baselines, but we haven't looked at renin at the population level, honestly speaking. You're on mute, Richard.
Thank you. Thank you. That's a really complicated topic. There's so many questions about that, so complicated. I wanted to go back to Kristen's. One of the members in the chat said, do you have any experience using high-dose vitamin C?
Yes, we were using it here for a while when the initial trial came out, kind of suggesting that they may be of benefit. And then I believe it's the Victos trial that kind of showed that there was no evidence behind vitamin C, and we all stopped using it. So that's kind of been my experience. I wonder if some of the things I talked about will kind of go the way of that, particularly the vitamin B. But I think we're all just kind of continually searching for things, particularly things like vitamin B that's cheap and readily available and may be of help, and that kind of clinically makes sense.
Yeah, I think the vitamin C craze, people felt like it can't be harmful. It's vitamin C, right? So let's give it a go.
Right, exactly.
Well, and then Kunal, someone just asked, is there a role for buprenorphine in the ICU opioid withdrawal?
I think that's a good question and an interesting one as well. I mean, again, some patients who are on chronic buprenorphine, we want to continue them as much as possible if we have enteral access or not. Now, regarding patients who develop acute withdrawal in the ICU, again, it might take some time for the buprenorphine to kick in. It still may be used. I think traditionally we've used, I think the alpha-2 agonists like dexmedetomidine and clonidine, if we have that option, because they kind of, suppress the cravings and stuff, and then transition them to buprenorphine. I don't know if someone's acutely withdrawing, if buprenorphine would be able to act that fast, and especially in the critical care arena.
Yeah, it does seem like more of a long-term medication. Somnath, someone asked about if you used haloperidol or clopidogrel or compazine.
I think that was directed at Kunal, but I mean, I do not have any experience with I used Haldol quite liberally, but the other ones we don't quite use. So that's not been my experience. But Kunal, since it's probably directed at you, anything that you want to add?
I agree with you. I think Haldol is a great drug in critically ill patients. I mean, I use it very liberally, and I think a lot of people use it. As far as chlorprozine, I think it's mostly used for PONV, but I haven't used it for sedation in the ICU. But I think that comment was from someone in Nigeria, and I think they're maybe restrained in what they have and what they do not have. So they may have a better experience with that drug, but as you said, I think in the US, I don't think many of us have used it for sedation in the ICU.
Yeah, I would echo that, mostly for the antiemetic effects. There's a recent, Kristen, I think this is directed to you. It's a question about vasopressin and nutrition. And they're saying, how do we address this since there's such a variation in clinical practice? I assume they mean high dose vasopressin and maybe potential gut ischemia. And if you feed patients on vasopressin.
Sure. I think that certainly the guidelines from the FAST trial were to keep that vasopressin dose relatively low at 0.3, 0.4, and that is, in my experience, how most people practice to avoid some of those issues with gut ischemia. In my review of the literature, in terms of at what pressor dose we should be not feeding people, which I think is a really common problem that we have here in the ICU. I have not seen any particular dosing of any of our vasopressors to suggest any sort of cutoff, which may be helpful. But I think at least I feed people through our kind of vasopressor cutoffs of 0.03, 0.04, as long as the other adjuvant vasopressors that I'm using are not at high doses.
Is that everyone else's practice?
Yeah, I don't really worry about thresholds. If my patient's on a stable dose of vasopressors and there's no other evidence of acute organ system failure, acute new organ system failure, then I will continue to feed. I guess there is obviously controversy around what would be that appropriate threshold, if any, to stop feeding. Some people say, well, if the patient if you don't feed your patient, then are you actually inflicting more harm than good by sort of starving the gut? So I personally definitely keep trickle feed going, if not full feed.
Great. Somnath, I had a question for you about the post-ICU clinics. Is that something that insurance is covering, or do you have to fight for reimbursement? How is it working financially?
So we have one which is in its infancy, quite honestly, and it's again, it's for the ones who go there. It's kind of listed as like a follow-up. So it's still, as I would say, the financials and other things have not been worked out from a viability standpoint, which is why it's not something that's picked up in a big way. But there are other institutions who kind of have clinics which are up and running, which have been there for a while, but they've kind of figured out the financial aspect. But I think in any case, in order to make a case for having a service line, you have to show definite benefit. So I think we are not there yet, which is why patients which like places which don't have it are kind of reticent and to kind of start something. And plus, there's always this concern about staffing. Like as it is, we cannot staff our units, staff other services appropriately. So why take something on like this? So that's the usual back and forth.
Great. Anyone else have a post-ICU clinic that's up and running? We don't.
Our medical ICU group has one, but I'm not sure on how they're staffing it.
Yeah.
No, so again, just as a full disclaimer, like the one that we have is run by the medical folks, but we work with them closely. So we are trying to, and again, this is very, very preliminary. We are trying to figure out ways by which the support can be given by ways which are not clinic based. So it's trying to like, so that's the overarching idea. Let's see if we are successful or not.
Well, that's great. I think we are probably at time. Does anyone else have any comments you'd like to add?
I think there's a question about clonidine or dexmedetomidine. I just want to say, I mean, again, depending on if you have enteral access or not, if you have enteral access, clonidine would be great because you can then transition them out of the ICU on clonidine, versus if you use dexmedetomidine, you're going to eventually transition them to clonidine when you have enteral access. So I'm going to leave it at that.
I agree with that. Well, thank you everyone for joining. This was a great panel, and special thanks to all of our speakers. Those were excellent talks. Very much appreciated.
Thank you, everybody.